Hello and welcome to another Sagely Health webinar. I'm Jeremy, CTO of Sagely Health, and I'm joined as always by Dr. Jason Sager. How are you, Jason?
Hello. Good, Jeremy. Hi, everyone.
So, April is Head and Neck Cancer Awareness Month. And so we usually use these months to kind of make sure that we do a webinar that kind of gives an overview of that type of cancer. So, with head and neck cancer, it's a pretty broad category that has to do with the region of the body, and there's a lot going on with any cancer diagnosis you get in that area. So let's just start there, Jason. Like, why is there a category called head and neck cancer, and kind of what makes that up?
Yeah. And Jeremy, from my perspective as an oncologist, it's important to acknowledge sort of the historical sort of evolution of things, right? So, when doctors started looking at cancers and there was a group of cancers in the lung, they would call that lung cancer. And there was a group of cancers in the breast, they call that breast cancer, and et cetera. Obviously, the head, the neck area with the mouth and the esophagus and everything that connects the two, that's all in the ear, nose, and throat area. So the doctor who would frequently see that patient was an ear, nose, and throat doctor, and thus it became head and neck cancer. Fast forward, we know that cancer is actually different depending upon the different places that it arises. And we'll talk a little bit about the causes of cancer, such as tobacco, and where if someone is smoking tobacco, they'll get lung cancer, but they can also get cancer throughout the tract. If they're chewing tobacco, they might get it in the mouth area. And then there's other viruses, such as human papillomavirus, also called HPV, that can cause a head and neck cancer in a specific portion of the throat. And so these are we're beginning to understand that they're not all just the same, they're disconnected. Move one step further, we start to introduce tumor sequencing and genetic analysis of the tumor, understanding at the DNA level what's actually driving these cancers. And there we can see even more differences. One patient may have EGFR. Another patient may have a mutation in EGFR and not have that. There's so many millions of varying factors. So, from my perspective, it sort of breaks down into a few different categories. There's sort of prevention and early detection. There's sort of the nuances of human papillomavirus. And then there's really understanding if you're on sort of the standard path of treatment or if you're at high risk and a good candidate for needing personalized treatment. And that personalized treatment is frequently found in clinical trials. And so today I'm excited to show you guys a little bit about some of the newer trials that I was just reviewing for head and neck cancer.
Okay, great. I have a couple of topics I'd like to go into. One is probably pretty quick, but I think it's worth addressing if people aren't that familiar. You mentioned that human papillomavirus, HPV, it can be a cause of cancer. And I think that could lead to confusion. Like, we all kind of feel like we can't catch cancer. That's not something you can do. So most cancers are not caused by a virus. And for a long time, it was believed that no cancers were caused by a virus. And so HPV does represent a virus that can cause cancer. It can cause cancer, I think, with head and neck, it's a certain type of throat or esophageal cancer.
Yeah, that's correct. It actually, again, it's a variety of locations, but it's sort of in the mid mouth and then back to the upper throat. So if you mention the oropharyngeal area, which is the back of the throat, you've got your uvula, also known as the punching bag. That's a medical term.
Dangling.
And then
Yeah.
and you've got your your tonsils there. And so if there's a tonsillar cancer, 60% of those will actually be HPV positive. So the majority of them are going to be caused by that virus, right? That you'll see the virus inside or remnants of the virus. We should mention that just having the virus is not a predictor for getting
Right.
cancer. So many people have the virus. Now, there are fewer people today because there is a vaccine for HPV and highly recommended that everyone eligible get the vaccine. And I think they are vaccinating teenagers now, both boys and girls, so that they will avoid getting the HPV virus that could set up for cancer later in life. And so that's by far a great thing. Obviously, not smoking, not using tobacco is also another great thing. And if you are using it, stop and get yourself help in stopping. But those things are the things that we can do to try to prevent the cancer from arising from these knowable causes. Unfortunately, as you mentioned, there's a lot of unknowable causes or things that we just can't control, just circumstance wise, sporadic cases of cancer. And so we always do the best we can, but know that if something happens, catching it early is really important. Which is what leads us into why you get your neck felt over when you go to the dentist office, because it's now become the dentist's job. Since they're working on your mouth, they can screen for oral cancer while they're doing your cleanup, your checkup.
And so when I go to the dentist and I'm getting a checkup and they're feeling around my neck, that's them actually looking for some type of lump or hard area that should not be there.
That's right. They're looking for a lymph node. Those, everyone gets lymph nodes swollen when they have an infection, and those infections can be pretty minor, like a scalp itchiness or something like that can sometimes blow up these lymph nodes. But something that is firm, it's not movable, like it doesn't kind of roll around. It may be expanding. It doesn't kind of, come and go. It's sort of just increasing slowly over time and is not painful. You can't feel cancer. It's not the same as having an inflammation from infection. And so those are signs that, hey, I should get this checked out. And again, it can be a lymph node out here. It can be a lymph node in the mouth. And you'll at some point, they'll probably grab your tongue with hopefully a piece of cotton or gauze and kind of move it around and be looking and maybe even probe down in the bottom of your mouth. It may not be the most comfortable thing in the world, but what they're looking for is any signs of that cancer, anything that feels differently to them than what they normally encounter. And that would, get you to another physician, probably a head and neck doctor for a biopsy or a check over. There's actually some dyes that can be used to take a look at this and to see how far things have spread, and all kinds of technologies have been invented. But it all starts really in that dentist office. And if your dentist is not doing it, you should ask them to do that, right? Say, doc, can you make sure that you take a look at make sure I don't have head and neck cancer, please.
So I'm hearing four factors. One is kind of some choices around tobacco, alcohol consumption, things like that. There is HPV, which can be a factor. You said 60%, but that means 40% of that type of cancers weren't influenced by HPV.
Right.
You have your genetics. You might have mutations that get passed down from your parents that could make you a little bit more susceptible, but not necessarily guarantee anything. And then you have what you call, I think, sporadic, where there's just cancers form when cells are duplicating, and we don't have the full insight to why that happens all the time.
Right.
But you see that there are some factors you can influence. And I think that's kind of really important to point out, one of which is getting the HPV vaccine when it is offered, and then kind of understanding that tobacco and other things do have their risks. It does not guarantee, but yeah.
Right. And in past weeks, we'll be reviewing some of the cancer vaccines a little bit later. Just, we've reviewed these vaccines in previous webinars or talks. There is a difference between the preventative vaccine and something you would take for cancer. And so we'll talk about that. But I want to just make sure everyone knows we're talking about the preventative one right now.
Absolutely. Absolutely. So I assume two things that are true with head and neck cancer, they're true with most cancers, that incidence rise as people age, that you're more likely to be diagnosed as you get older. So if you're sitting in the dentist chair and you're getting on in years, it's definitely something that should be checked. And then the other I will come back to when I can think of it. I can't remember what the other one was. So
just to comment on that, though, cancer, there are interesting trends in cancer right now. In colon cancer, for example, they're seeing it earlier and earlier than they ever have before, and we don't really have a good explanation for it. So even though you expect that it'll be later in life, the fact is that, that screening can happen at all stages in life and should happen basically, every year. And so, again, if your dentist is not already doing it, please ask them to do that. And there are lots of resources to help find out about, there's head and neck advocacy groups that will teach this like 5-step screening course. Again, it's made not to be difficult, but it is really helpful. So,
Well, it brings me, I did remember the other thing, which is the earlier you catch it, the better. So the
absolutely.
importance of screening and the importance of not delaying. I mean, we unfortunately do meet patients who said, "Yeah, I've been dealing with this for a while. I didn't want to, go to the doctor. I was kind of afraid of what it was. I didn't think it was that serious, though." And it's kind of like, well, it may or may not be serious, but the earlier you
Yep.
kind of get an oncologist, radiation oncologist, a medical oncologist looking at this, the better. So
Yeah. Yes.
that,
And actually, you bring the, and screening is always, early detection is always the best way. I just had a family member yesterday, not for head and neck cancer, but a different kind of cancer. And it's like 7 millimeters. It's so small that it's going to be a one and done, right? They're going to get it removed. There may be some radiation involved, but the expectation is they're going to be cured, that the standard treatment path will bring them to vast majority, 95% success in not having to worry about this again. The more time goes on, the lesser that chance becomes, and the more chance that you're going to be in that sort of personalized medicine. And again, we're going to do the best possible, but it's always much better to catch it early.
yeah, and that I want to. So let's just talk about treatments, maybe kind of the standard treatments that you would expect, and the factors that might go into what makes those available to you or not. And so you just talked about finding an extremely small tumor, which means that it is resectable,
Yeah.
operable. You can have surgery, however you want to use the terminology, but it can be removed.
Yeah.
So, what are other ways? Is that the preferred way to
Yeah.
deal with it in most cases?
Yeah. So for head and neck cancer, actually, radiation also figures in very strongly. We know that these cancers are generally radiosensitive. And so usually radiation will be combined with whatever the other modality is, whether that be surgery or chemotherapy or immunotherapy. And we'll talk about that. But certainly, radiation has become one of the standards. And as such, photon radiation or proton radiation, as opposed to photon. Photon's the traditional, proton is the new one, and proton is more focused and so has less side effects outside of the immediate tumor area. Therefore, we always recommend getting evaluation for proton therapy whenever therapy is part of the treatment path for you. And so it's just something to look into. But yes, these different modalities are combined together in order to create the best possible outcome for the patient.
And then, just like other types of cancer, should surgery be done or biopsy is done, that sample can be
Yeah.
sequenced. And so I think we often talk about sequencing as, I would like to live in a world where the cost isn't a problem and everyone can get, their tumor sequencing so that we build up data around all types of cancer and that sort of thing. But we often have to deal in the realistic that who should get next gen sequencing. We talk about risks. So could you talk a little bit about when with head and neck cancer you should really be thinking about the tumor sequencing as opposed
Yeah.
to maybe being a lower priority
Yeah.
or for
Yeah.
later?
So, assessing that risk can be difficult for patients. And again, that's why one of the reasons that we exist is to help patients to do this. We've actually developed an algorithm, a way of, getting information from patients. And it really does collect the information about how big is this? How deep is it? Where is it located? How, is it related to HPV or not? And on that basis, we would then recommend either, no, you're going to be fine. And when we say you're going to be fine, what we said is our bar is 80% or more of cure, right? So, the chance is overwhelmingly likely that you're going to be cured. Anything other than that, we would say, well, let's get an insurance policy on that and get a tumor sequencing now. The issue is you don't want to wait till later, because if the cancer does come back, no one's going to want to wait the 3 weeks to go get the tumor sequencing at that point. So getting it up front can really help to prepare for just in case this should come back. And then there's other patients where if it has spread or is in multiple lymph nodes, we know the risk is extraordinarily high, almost likely that that will come back. And therefore, we can start to advise patients that, perhaps before surgery, there is a treatment called neoadjuvant treatment. And one of the therapies we'll review today has that in there, where we can pre-treat that tumor, shrink it down, make the surgery or the radiation easier, and decrease the likelihood that that tumor is going to come back later. And so all of those things are incredibly important. But again, we personalize it so that if a patient has a very high likelihood of success with the standard treatment path, we just send them down that path. If they need the personalized treatment path, we're going to make sure that we help them to identify the best possible treatments to get the best results from it. And then the middle zone is where that tumor sequencing can really help as an insurance policy, just in case it comes back, and then we're ready to go.
Great. Well, I want to get into the kind of more innovative treatments, but before we do that, I just want to do a plug for, if you are diagnosed with head and neck cancer, as with most types of cancer, that pathology comes back and you've got a diagnosis, you may be sent to a medical oncologist, a radiation oncologist, or a surgeon. And you do not need to just kind of stick with the one that you're sent to. If you're sent to a surgeon, even if that surgeon says, oh yeah, that's simple, we'll get that out, never comes back, it's cancer, it's your life. Ask for a referral to a radiation oncologist as well. Ask for a referral to a medical oncologist as well. Meet with them. Ask them to speak with each other about your case. You may end up with the same surgery or radiation that you would have gotten before, but most cases we see there are slight changes, and they're changes that we're generally very happy about, like having neoadjuvant radiation before surgery if it's appropriate. And we can't tell you right now about your case because there's so many factors if it's appropriate or not. But what we can tell you is involving those three professionals leads to a better outcome.
Mm-hmm.
So, and that's been proven out by why we have tumor boards and kind of other approaches, the interdisciplinary approach, and it's available to patients, but sometimes they got to go get it.
Right. They have to request it. Exactly. Yeah. The other thing that I would give a plug for is, for a patient who's getting diagnosed, it's always good to get an opinion or be seen by an NCI-Accredited Cancer Center. They do specialize in each of these cancer types. And as we get more and more in depth on understanding cancer, we know that it's really important that the accredited cancer centers are doing the research to do the best they can, and they have the clinicians, the doctors there to see the patients who really subspecialize. So at MD Anderson, I think there's a specific doctor for HPV positive head and neck cancers. It goes pretty in depth. So any NCI accredited cancer center, and again, there's a website for that by the government, the U.S. government. But if there's any questions, we can always help to point patients in the right direction.
Absolutely. Excellent. So let's talk a little bit about what's going on in clinical trials for head and neck cancer.
Yeah. So, almost surprisingly, so I did a search for head and neck cancer, and, 272 trials popped up, and this is in the U.S. We can, take a quick look at the map, and you can see that they're distributed. Our computer system sort of puts them together in groups, but as you start to spread out, you can see that they're really quite prevalent all over the place, which is fantastic. So I think the message there is that any cancer patient in any location will be able to find something innovative if they need to do that. I've gone through, and again, not in any rigorous way because there's so many. Right, 272, but there are flavors of these that I thought would be helpful to review. So, one of the first ones to talk about is just the involvement of that immunotherapy. And immunotherapy was discovered now about 15, 20 years ago, but really has been advancing in how much it's been used. And when I say immunotherapy, what we're talking about medicines that instead of attacking the tumor directly, really work on the immune system and allow the immune system to attack the tumor and really kind of stimulate it to attack the tumor. In the case of checkpoint inhibitors, which is led by this drug called pembrolizumab, also known as Keytruda, the way it works is by that pembrolizumab kind of forces the cancer to decloak itself. So it kind of has this cloak of invisibility from the immune system that it learns how to produce, so to evade the immune system. And then pembrolizumab in specific cases, melanoma being the first one, but head and neck cancer here has really, it can work to decloak that tumor and allow the immune system to see that tumor and then attack it. Now, unlike melanoma, head and neck cancer, it's a little harder than that. So we don't just use it alone. And that's really where a lot of these clinical trials are now centered, in the combinations of these immunotherapies with other approaches. In this case, there's a drug called lenvatinib, which is a tyrosine kinase inhibitor. This is a drug that specifically attacks the cancer, but in a targeted way. So there are growth factors that and receptors that are driving that cancer to grow. And so this one is putting those two together in a way of doing better. And again, it's a trial. We don't know how well the outcome will be, but I have a guess, which is better than the standard, better than what patients who have relapsed or otherwise metastatic, widely spread cancers will have benefit from. And so this is a viable option in those patients.
Yeah, to make it really clear for folks if they're kind of new to this, is you have a head and neck cancer, a tumor may form, and when we talk about advanced or metastatic, that means that it has spread. The original site is in a head and neck, kind of what got classified as that, and that's the cell that's moving somewhere else in your body and creating kind of other cancer cells. So at that point, a surgeon can't go in and find it all. They can't cut it out. They can't get it. So now we're saying it's got to be something more systematic, which
Mm-hmm.
is, can be radiation, can be chemotherapy, and can be now
Right.
other things like
Right.
immunotherapies and targeted therapies.
Right. And the standard is still the platinum chemotherapy agent. So you'll see here that this trial is specifically for patients who have already received platinum therapy. And again, because immunotherapy now is known to be effective, patients as a standard in that advanced or metastatic group will receive platinum and immunotherapy. And so now these trials are coming on after that. Because unfortunately, we know that these won't usually cure the patient, but we can create a situation where the patient can live with a good quality of life for years, and that becomes then our objective, is to not die from cancer as opposed to curing it. And living with cancer is something that we're able to achieve in more patients than necessarily look at it as a cure sort of situation.
Absolutely.
Yeah. So this is, this next one I pulled out because it does represent some of the other immune approaches. I think I've got a vaccine a little lower below. This one is actually a virus that is being used to infect the cancer cells, and specifically, and they'll oftentimes either put it on, because if they can get it locally because it's on the surface for head and neck, or they'll inject it into the tumor, and then they combine that with one of these immunotherapies. So now you've got sort of a combination approach where you're trying to, decloak the tumor. At the same time, you're trying to inject something that will basically tell the immune system, look here, attack this place, right? And so it's sort of a double-edged sword in trying to attack cancer. So I pulled it out. It's very interesting.
Wow.
Yeah.
That's a new one to me. Yeah.
Yeah. These oncolytic tumor viruses. Yes, that's the general group that they call them. Um, There's other ones. This one I pulled out because we talked about neoadjuvant. So if you have a tumor that is at high risk, stage 3, stage 4A, so you're basically, the likelihood is that this is going to come back at some point. What we're trying to do is see, well, if treatment before surgery will help to prevent it from coming back after surgery. And so this is a trial that's aligned towards that purpose.
That's a good point to make is, there are well over 10,000 clinical trials for cancer running in the United States right now. And some of them are looking for dramatically new types of treatment, hoping for kind of a big grand slam home run. Pembrolizumab comes to mind, that something's really going to change. And there's other trials that are saying, how can we improve? And so, you can maybe find that trial, but that's kind of why you want to get to one of those NCI accredited cancer centers and bring this up with the doctors and say, like, what are you guys doing to try and improve on this? Which means that you might just get access to better diagnostics, better attempts at things, and something that may have very few other additional side effects than this standard would have, and you're just getting something that just has a better chance. That's why they're doing the trial. That's why they're investing the time, because they truly believe that this is going to be
Yeah.
improved.
Exactly. And a few things. What's more, first of all, it's hard to figure out which one is the right one for you, which is why, we get involved. There's others that do this too. Tumor trial matchers. But what's really important, you mentioned going to your doctor and asking them. What we know is that, what we'd like to do is to make sure that, and here's a list. I mean, there's a lot of centers that are on this list. But for example, you might be at Mercy Medical Center, and yet University of Maryland is right down the street from you. But Mercy Medical Center won't know what University of Maryland is doing necessarily, and so they're both. In this case, this is a different Mercy. I was talking about the one in Baltimore, but in any case, they don't talk to each other, and so what we want to do is to make sure that when you're at risk, you can get to a center that has one or more, and our preference is to have several
Right.
options for these clinical trials for you. That's when we've seen patients do their best, and that's sort of how we sort of go in and help patients to connect with these innovative therapies. I mentioned that radiation therapy is a standard, and here they're combining radiation with another drug. In this case, it's called cetuximab. This is an older drug, but then there's a newer drug, and this is this radiation activated small molecule that hopefully is doing better. And again, this is pointed for the elderly and who wouldn't normally be able to tolerate the strong platinum-based chemotherapies that's part of the standard regimen. And so this is a trial that's appropriate for those patients. And you can just see the variety out there.
Yeah.
This is another type of therapy that is called an antibody drug conjugate, where you have an antibody which attacks a protein on the cancer, and you've attached to it a potent chemotherapy like a toxin. And so it's not like the whole body is getting toxin; it delivers it right to the tumor. And it's engulfed by the tumor or by the cells around the tumor, and therefore it kills the tumor selectively. I mean, really, really exciting, futuristic science. Unfortunately, or fortunately, the early cancer screening, which everyone can do, is more important than all of these.
Yeah.
That being said, when you run out of options, or you're running out of options, or you're at high risk, this is great stuff. And the fact is that we're all working towards a day where a lot can be prevented, and the ones that occur because it's sporadic and no one can prevent them, they can get treated and cured. And that's what we keep on working towards that end point. I guess the only other one I was going to bring up was this one, which is again an HPV-16 cancer vaccine. And again, this is not the same thing as a preventative vaccine. This is made to try to stimulate the body to attack the cancer, which has come from the virus. The virus, after it causes the cancer, is no longer really important, but the cancer itself is different than other cancers. Generally, HPV positive cancers do better, but this is, and one of the reasons is because they have more, therapies to try to approach it specifically in a personalized manner. And so here they're combining that cancer vaccine with sort of our favorite pembrolizumab being one of the prototype of the checkpoint inhibitors. And so immunotherapy plus this cancer vaccine tries to get rid of the tumor. So you can see science and the doctors really trying to approach this with so many different angles. We don't know which of these is going to be the best, but we know that on average, these are better than what is going to be the standard approach, especially once the standard is used up and no longer an option. Then really this is the way to go.
Are there certain gene mutations that are more prevalent in head and neck cancers, or is it kind of the same ones we kind of suspect in other types of cancers?
Yeah, it's a good question. There are specific, I'd say mutations that tend to be more represented in head and neck cancer, but overall things like the PDL1, which is the marker for this sort of cloaking immunotherapy approach, that is present in a proportion of every cancer. And so it's really important because we were looking at rectal cancer a few weeks ago, and how immunotherapy there can cure patients with a with something called MSI high, or mismatch repair deficient cancers. That's a synonyms for the same thing. But there it's all based on the genes, and every cancer will be analyzed for that. A proportion of head and neck cancer fits into that too. And in that case, then you really need the immunotherapy, and you may not need the chemotherapy so much. So again, the treatment process becomes personalized.
Great. So I think we can probably wrap up there. I think that, there's been a theme that's gone across a lot of these webinars we've done where we've tried to look at things, which is it's very hard to understand risk. It's you're diagnosed, you're then talking to doctors that you've never seen before, you're talking to a surgeon, you're not talking to a surgeon, kind of. That's where we fit in. I mean, it's very hard to understand your risk, and then once you do understand your risk, it's hard to know what actions you should take and what actions you should not take, and kind of how you should think about it and how you should approach it. So I mean, I just want to point out, like, we just talked over a couple of these. There were well over 200 results here, and we could even widen this search, I think, further. So it's something where you may not be offered an innovative treatment. Actually, let me just rephrase that. You will not be offered innovative treatment. And so you can, though, see what's out there. And that's why Sageway Health exists. I imagine that's why others like Sageway Health will exist in the future. There's this huge gap in kind of where you go from being diagnosed in your local community to reaching the best possible treatments for you.
Yeah. And one of the avenues that we have, and I agree with you completely, one of the avenues that we have available to us to help patients, that they come to us seeking the questions they should ask. And again, we're able to provide that. One day, I hope to be able to do that for millions of cancer patients. But today we do it for handfuls, and that's good, a good start. We do this in a personalized way, but in a way that really asks the question in a very nice way to the doctor. Is our clinical trials right now even reasonable to consider? What is my risk of this coming back? Would you say it's greater than 20%? Is it like 80%? Is it 50%? Is it, you want to hear that it's like way less than 10%, right? I mean, but if they start hemming and hawing, then get a second opinion, right?
Yeah.
And so, this is how we help to guide patients with sort of the questions that they can ask the doctor. The doctor is expecting them to ask questions. Patients that arm themselves with the best questions tend to do the best, to me.
All right. Well, that's probably a good place to wrap it up. Thank you, Jason. This has been really great. And I'll just say our website is sagewayhealth.com. If you've got any questions about head and neck cancer or any other type of cancer or anything related, please reach out to us. We are always available.